Hello and welcome to Basic Dysrhythmias, Nursing 183. Today we're going to do lecture a little differently than we have in the past. We are going to have the lecture online, and then I'll have you come into class and we'll practice the ECGs. So hopefully that will end up with a shorter, it will end up with a shorter classroom time in the classroom. But you will have this lecture so that you can actually look at each individual slide slower and at your own leisure, which you know I'm always talking pretty fast. But anyways, so let's get started. Today we're going to go over how to do ECGs. It's a little strange for me to be talking to you through the microphone, but I'll try and add all my little stories as much as I can. First off, today we're going to be looking at basic dysrhythmias. That means that we're going to look at the most basic arrhythmias, the ones that are normal as well as the ones that are abnormal and life-threatening. In third semester, you're going to go over some more chronic type of dysrhythmias. You're going to be looking at the atrial fibrillation, atrial flutter, and some of the other atrial arrhythmias. And then in fourth semester, you're going to combine it all together with Rita, and actually, I believe at that time she actually gets you certified for ECG, which is a great thing to have before going out with your license. So let's get started.
Hello, this is a sample test.
Today, we're going to first review some of the cardiac electrophysiology. First off, to interpret ECG rhythms, you must understand the electrical and the mechanical activity which is occurring within the heart. And I personally like to look at it as that the heart is a structure that, like plumbing, that functions. You know, I like to talk about plumbing, that it beats and moves the blood through the heart, but there's also an electrical system there that actually initiates this beat. And so we need to have the electrical system working well, and we need to have the pumping structure working well. And so today, though, when we're looking at the ECG and analyzing ECGs, we're really predominantly looking at that electrical force. It's telling us how the electrical current is going through the heart. So, looking at the electrical properties, there are specialized cells within the heart that can discharge an electrical current. This property is called automaticity. It initiates the electrical activity. In other words, it tells the heart to beat, and it conducts it through the heart. And so we need these electrical or conductive cells in our heart to be able, and we need them to be healthy and functioning well for our heart to initiate this electrical activity. But we also need mechanical or contracting cells. These cells respond to electrical stimulation. They contract to pump the blood, and this is where we get the mechanical beating or the contraction of the heart. And so a person will have both the heart rate and a blood pressure. So we need both of these type of cells functioning for our heart to be able to function and give us that heart rate and that blood pressure. If just the electrical is working, we will not see this. We will not see a blood pressure. We will not see a heart rate. We might see the electrical going across the ECG, but when we go to feel for a pulse or try to get a blood pressure, we will not see it if the contracting cells are not working. Also, we will talk about these terms depolarization and repolarization, and I think you'll probably hear more of this with Rita than with any group. I'm just going to start you off on it. I just need you to understand that in the heart, there is depolarization and there is repolarization. So I think you studied this in physiology. So what happens is when the cell is resting, the potassium is inside the cell and sodium is outside the cell. When cellular depolarization occurs, that interior cell becomes positively charged and the cardiac cell will contract. And what will end up happening is the movement of sodium, and it contracts. I'm sorry, I'm stuttering over myself. And it will contract due to that movement of sodium and potassium across the cell membrane. And now the potassium has gone outside and the sodium is inside. Then we have where we have repolarization. So it goes back to resting. So what's going to end up happening is that it's going to return to the potassium being on the inside and the sodium being on the outside. And this is important because certain medications are given based on this, as well as we have certain PVCs that we're going to be concerned about when they're occurring in the cycle of depolarization and repolarization. So you need to kind of file that back in your brain as we advance you through the different levels of ECG analysis. We need to know the conduction system. This is there's a conduction system where there's specialized electrical cells in the heart are arranged in a system of pathways, and it's called the conduction system. And these specialized electrical cells and structures guide the wave of that myocardial depolarization through the heart. The physical layout of this system is that the SA node, or the Sinoatrial Node, the AV node, or the Atrioventricular Node, then the bundle of His, which is also sometimes known as the AV junction, and then it goes into the right and left bundle branches and finally ends at the Purkinje fibers. And there we have a picture of the SA node starting up at the very top left-hand section, and it's moving down through to the AV node, down the AV node through the bundle of His into the right and left bundles, which then have the Purkinje fibers. Boy, I'm slurring that. Let's look at the first part of this pathway, the SA node. It's located in the right atrium, up on the posterior wall of the right atrium. It's known as the primary pacemaker of the heart because it has the greatest automaticity located here. It normally, its intrinsic pacing rhythm is going to be about 60 to 100 beats per minute. And as a result, we get atrial kick from this. Atrial kick, when we talk about that, is when the atria contract and they add an extra force of cardiac output into the heart, and that actually makes up 30% of the cardiac output. So if we are at any point in our time lose that where the atrium is not functioning for us, and we see that happening in some of our heart blocks, we see it happening in atrial fibrillation where it's not functioning as well. When the atria do not contract the way that they should during this period of time, we have lost the atrial kick, and that is about 30% of our cardiac output, and that's very important for our patients. It's very important for maintaining our blood pressure. The second place along the pathway that we're concerned about is the Atrioventricular Node, the AV node. It's located in the lower portion of the right atrium above the base of the tricuspid valve. And it actually is just a relaying center. It delays and relays the impulse into the ventricles. After this is the bundle of His and the right and left bundle branches. The bundle of His, also known as the AV junction, is located in the upper portion of the interventricular septum. And the pacemaker cells here are capable of discharging a rate, or the intrinsic rate, of about 40 to 60 beats per minute. This is called our backup pacemaker. Our SA node is our primary pacemaker, and this is our backup one at a lower rate. And then after that is our Purkinje fibers, which is the terminal ends of the bundle branches. It is the third and final pacemaker site. It paces at a rate of about 20 to 40 beats per minute. And here is a summary of the pacemaker functions with the primary or level 1 SA node beating at 60 to 100, with the backup system 40 to 60 at the bundle of His, and then the final one at Purkinje fibers. So of course we always want the SA node to be functioning. When the SA node does not function for whatever reasons can happen, it can be due to disease of the heart, it can be injury to the heart, it can be drugs, it can be medications. If any of these things stop the SA node from functioning, then the bundle of His or the AV junction will then take over. And of course, if this part of the heart is injured, then or in some way compromised, then the Purkinje fibers would come in. And so we can sometimes see by how slow the heart rate is where the damage has occurred on the pacemakers. But we certainly are lucky that we have 3 different levels and 2 backups for us. Now let's look at how we look at an electrocardiogram or ECG tracing. It is designed to give us a graphic display of the electrical activity in the heart. The ECG cannot tell you about the mechanical activity of the heart. You actually have to assess the patient. And the way that you can do that is you have to assess their pulse and their blood pressure to see what is the mechanical activity that's going on. But the ECG will tell us the electrical activity of the heart. Monitoring systems are used to be able to give us this information. The most common ones that we see are the 3 and the 5 lead system. These are color-coded cables. The negative, let me move to the next one, but you'll see here various different ones. And the nice thing about it is they're color-coded, and they'll usually tell you where to put them. Especially, I know you've worked with the ones at Tri-City, that it tells you exactly where to put them, and I love that. So, where do the leads go? Well, negative is usually white, and positive is usually red, and then your ground color is either a black, a green, or a brown. The leads are going to record the electrical activity between 2 electrodes, and it's from each lead has a negative and a positive electrode, and we're able to see that recording of the electrical activity between those 2 electrodes. So the placement of these electrodes will allow you to have a view of the heart. Depending on where you put that negative and positive, we'll be able to see where the picture is of that electricity going through the heart. Electrodes are adhesive pads that contain a conductive gel and are attached to the skin of the patient. We need to have a good ECG signal, so this means that it has to have good skin contact. So sometimes on a diaphoretic patient we have to wipe them down, sometimes use some alcohol and try and cool it off and dry it up. Sometimes on a hairy patient's chest we have to shave off some of the hair so that we can actually get a good skin contact. Also, you have to make sure that your electrode has a good skin contact, good jelly there, adequate amount that isn't dried out so that it will stick. And usually most telemetry nurses will change their electrodes every 48 hours. Common leads are lead 2 and MCL1. Looking at a lead 2, this is where the white or the negative lead is placed on below the left pectoral muscle. I'm sorry, the white or negative lead is placed below the clavicle. Sorry. And then the positive, which is red, is placed below the left pectoral muscle. And so then the ground is placed on the left under the left clavicle. And so what we get here is that an acronym that they like to say, smoke over fire. So we have the fire down below and the smoke up above, as you can see in this slide. This particular lead is preferred by some nurses. I'm one of them. I like lead 2s because it has a nice large upward deflection, and I just find it really easy to read it. but a lot of our coronary care nurses really prefer the MCL1, and so let's look at that one. MCL1 is a is a modified central lead. It is where the negative electrode is near the left shoulder and the positive electrode is near the sternum in the fourth intercostal space. Now, let me show you how to figure out where the fourth intercostal space is. But you will see that when you look at this EKG rhythm or ECG rhythm, it is a very different configuration. It's more, the QRS is more downward, and you'll see that ST is down as well. Now, the thing is that when we're working in the hospital with different electrodes, we put on all these electrodes, and then we can dial the monitor at the station to where we want it to be, or even at the bedside. We can, if we have a bedside screen, we can dial it to what lead we prefer. So you'll see that a lot of people will move it to lead 2, but you could see it through MCL1, and you could see it through lead 1, and you could see it through lead 3. All different ways you can look at it and see a picture of the heart. And so here is how you determine where that fourth intercostal space is going to be for your MCL1. You're going to first find the angle of Lewis, and then from there you're going to count down, finding the spaces between the ribs, and when you get to the fourth intercostal space, you are going to put the electrode there on the left-hand side. All right. So let's look at the paper that we use. ECG paper, it's a graph paper that's made up of small and larger heavy line squares, and there are 5 small squares between the heavier lines. So it prints, the ECG prints at a certain constant standardized speed, and so based on that, we're able to determine how long it's taken for that area of the heart has moved through it, and so we have come up with standardized amounts of times that we can predict certain wavelengths will go through. Each small square on the graph paper is worth 0.04 seconds. You do need to memorize that. And the large square, which is 5 small squares, is equal to 0.20 seconds. And you do need to memorize that one as well. This information will be essential for you for your ability to analyze ECGs. The standard practice is to print a strip for at least 6 seconds, and because of that, when we determine a 6-second interval, we're able to determine the rate as well. Based on 10 times 6 will give us our 60 seconds, our 1 minute, so we're able to determine the patient's rate per minute. So let's look individually at the different waveforms that we're going to see that are going to go on that ECG paper. The first one we're going to see is the P wave. This is an electrical impulse that's originating from the SA node. It is an indication of atrial depolarization. So the atrium is being depolarized. We're getting that atrial kick during that time. The next thing that's going to happen after the P wave is the PR interval. This is where it extends from the beginning of the P wave, which is that atrial depolarization, until the onset of the QRS. And so it is always when the beginning of the QRS starts, even though it says PR, it's the beginning of the QRS in which we measure it for the PR. So this length of space of time should be less than 0.20 seconds in duration. This indicates that that is the proper amount of time that the electrical impulse went through the atrium. This is a really important thing to memorize, and you also need to realize that when this is extended out, this is sometimes a sign of some kind of a heart block. The QRS is the next wave that we're going to look at, and that is the ventricular depolarization. This is a large complex of 3 waves, the Q, the R, and the S waves, and each person's complex can look a little bit different. But regardless of how they look, whether it's the Q is going up or the Q is going down, everyone's is called a QRS. And the normal duration that a QRS should go through is 0.12 seconds. Now 0.12 seconds would be 3 small squares. And here we have the QRS, the ventricular depolarization, many different forms, and that 0.12 that I want you to memorize. Following after the QRS is the ST segment. The XT segment begins at the end of the S complex and ends with the onset of the T wave, and this is the early part of repolarization of the ventricles. And then it's followed by the T wave, which is the continuation of the ventricular repolarization. So how do we interpret ECGs? Well, first off, we interpret ECGs by analyzing the waveforms and seeing how they all interrelate. So we're going to look and see what is the interrelationship between the P wave and the PR interval and the QRS complex. We're going to look at the rate and see how fast the heart is going. What is the rhythm? Where is the site of the dominant pacemaker? And is the waveforms the proper kind of configuration that we should see? And then there are, when we look at certain heart dysrhythmias, there are certain salient features or features that are critical for that particular rhythm for it to be that diagnosed as that rhythm. So I will identify those as we go through these dysrhythmias, and then the final thing I have to say is you just have to practice, practice, practice. This is not something that just automatically comes to you. It's something that with time you get better and better at. So what do I do when I analyze a rhythm strip? I have a certain way that I like to do things. The first thing I do, because you know I'm mathematical, I like to do it the same way every single time, is I'm going to look at the rate. I'm going to calculate the heart rate, and I can do that by actually listening to their heart, but you can actually figure it out on the monitor. You can figure it out on the rhythm strip, or you can actually, lots of the bedside monitors just have the number right there. So you can cheat and actually get the number from there. But we're going to teach you how to calculate it. And then you want to look at the regularity. Is it regular? Is the all the waveforms going across in a normal way? Do you see the QRSs happening and marching across the piece of paper in a regular way, a regular fashion? And then we're going to look at the P wave. Is there a P wave for every QRS? Because there should be. And then we're going to look at the PR to a P to R interval, or the PR interval, and we're going to measure it. Is it under 0.20, which is under 5 small boxes? It should be. If it isn't, there's something not right there. And also we need to see, is that consistently the same length all the way across? Is it happening before every QRS? Is it dropping at any time? So we're looking at those things. And then we're going to look at the QRS width. We're going to measure that and see it should be less than 0.12, and that's less than 3 small square boxes. And we want to see, is it a normal configuration? Is it happening right after everything? And then finally, after we've looked through all those different things, we're going to interpret it. So, and I've got a flow sheet for you at the very end to help you with that. So, first things first, let's determine the rate. On every ECG, they have marks at the very top of the rhythm strip. You'll see where it says 3 seconds at the top of this rhythm strip. They'll have lines, and they'll have a line, and for each line it's 3 seconds. So the next line would be another 3 seconds. So if we were to count the numbers of QRSs between those lines for 6 seconds, we could determine what the rate of this rhythm strip was. So for example, in this one, in the 3 seconds, we have 1, 2, 3, 4 QRSs there. If we were to continue, assuming it's going at the same rate for another 3 seconds, we'd have another 4. So that would be 4 plus 4, that would be 8 QRSs, and so that would be 8 beats, and that's for a 6-second interval, so times 10 would give us 80 beats per minute. So that's one way to figure out the rate, and a very common way that most of us do figure out the rate. An older method, but one that I gravitate to whenever I can't figure out where the 3-second lines are, and also one that I hear that Rita uses regularly, is the rapid estimation method using the thick lines. And so you basically go by where the thick line is, or the number of large boxes. So if we were to look at this, you kind of have to, actually I have memorized this, what the number is. It's hard to believe I still know it after all these years. But if you look at the very first strip up here, and you look and see where the QRS is on a heavy line there, how many boxes is between that QRS and the next QRS? It's 1, 2 boxes. So that's 300, 150, and so that rate would be 150. Let's go down to the second one and see if it makes sense on that one. On this one, we have the QRS on that first line there, and then for every box, you're going to count. And so you'll see the first box is 300, the second box is 150, the third box is 100. So there's 100. So the rate of this rhythm strip is 100, and so on. Some people like doing this method. It is predictable, and it is one way to do it. Either way is fine with me on how you determine your heart rate. The next thing we want to look at is regularity. You'll see here different descriptions of a regular versus regular irregular, and a grossly irregular. The top one is regular. You can see that the QRSs march regularly across the sheet, as do the P waves. On the next one, they still do march out the same, but there's something in between there, and I know that that's PVCs. You don't know that yet, but it's a regular irregular. And then at the very bottom, looking at that, that's an atrial fibrillation, and it's very irregular. You don't see the P running regularly. You don't see the QRS marching out regularly, and so that would be irregular. Then I look at the P waves. Is there a P wave in front of every single QRS? Is it upright? Because it should be upright in lead 1. Is it uniform in shape? Are they all the same? Do they occur always the same? And some different ECG dysrhythmias will be diagnosed based on these sorts of changes. The PR interval we need to measure. Remember, what is the width? We need it to be less than 0.20. If it's greater than that, then we can diagnose the problem there. Are the intervals the same in front of every single QRS? Is every single one of those PR intervals the same length, same width rather? And if they aren't, that can be indication of some other kind of problem. Then we look at the QRSs, and the QRSs should be less than 0.12. They should be occurring regularly, and if they aren't, that can be a reflection of a dysrhythmia. And then finally, we're going to analyze it. Now, I don't want you to look at this flow sheet just yet, because this flow sheet can be a little overwhelming, but we'll come back to it after we've gone through all the different arrhythmias, and hopefully it'll make it clear. Now, one thing here, you'll see that in the very center there I have P waves. If they're fibrillatory P waves, it's AFib. If it's sawtooth, it's A flutter. We're not going to be studying those today. You're going to study those in third semester. We're just going to start on the basis, get you strong on that first before we move you on to the next level. So the common ECG rhythms that we're going to look at today is we're going to look at normal sinus rhythm. We're going to look at sinus bradycardia, sinus tachycardia. We're going to look at the heart blocks. Then we're going to follow up with PVCs, or premature ventricular contractions. And then ventricular tachycardia, ventricular fibrillation, and finally asystole. So let's get going. Normal sinus rhythm. You'll see at the very top of this page that I have a website listed there that you can utilize. It actually gives you practice on different types of rhythms. It does encompass all the rhythms, so that will be a little annoying to you because when you get an atrial fib, you won't know it, or an atrial flutter. But it will help you with other ones. And of course, the web has a lot of different sites that you can use to help you practice on this. So normal sinus rhythm. The predominant thing about normal sinus rhythm is that it is healthy. It is normal. We've got normal conduction, we've got a pacemaker that's functioning normally, and so consequently we're going to see a rate that should be about 60 to 100. So if I was to count this one out with the what was that method? Rapid estimation method. Whew. I don't even know what the method is I use, but still, if we were to look at that long line, I would see 300, 150, 100. I think I'm about 85 on this one. So 85 rate. Then the next thing I'm going to look at is I'm going to look and see, is there is it regular? I see the QRSs running across normally. I see the P waves running across normally. They're marching out perfectly, so it's regular. I'm looking at the P waves. It's upright and it's within and it's before every single QRS. I'm looking at the PR interval. It is normal. If I was to count this one out, it looks like it is about 3 to 4 small squares, so that's less than 0.20, so that's good. And my QRS looks like it's maybe 2 small squares, that's about a 0.08, so that's within normal. So everything's normal here. So the salient feature of this is it's normal, and the rate is between 60 and 100, so that is how I would diagnose normal sinus rhythm. Sinus bradycardia is another arrhythmia we're going to look another rhythm that we're going to look at, and the description of this is where the sinus node is firing regularly at a rate of less than 60. Now that is the salient feature about this, because everything else is going to look good except for the rate. Possible causes for this could be some kind of increased vagal tone, parasympathetic vagal tone, such as vomiting, or any kind of vagal maneuver. Medications can also do this, such as digoxin. And then, of course, our athletes are typically have a heart rate of less than 60. And even though I'm not an athlete, I also have a heart rate less than 60 when I'm completely at rest. So it's normal for me. And so it is important for a person to know what is their that they have a normal sinus bradycardia. So what is the collaborative care for this? What are we going to do? Well, first off, we want to observe and see, do they have any symptoms of bradycardia? So are they asymptomatic? Great. We're not going to worry about them. I'm one of those that when my heart rate gets that low, especially during surgery, I get really low. I am asymptomatic to it, and that's no problem. But people that might be symptomatic would show signs of shortness of breath. They can't cope with their heart rate being slower. They might have fatigue. They might have blackouts. They might become lightheaded and have confusion. If we had a patient with those type of symptoms, we would know that they were not tolerating their heart rate being lower. So what would we want to do for a patient with that's symptomatic? We would want to give them oxygen. So we kind of try and help them out with that, and we're also going to give them atropine to try and increase their heart rate, and then we are going to consider some kind of pacing. We usually start with a transcutaneous pacer, which is a temporary one, and then we'll move it into a permanent pacemaker. And you'll talk more specifically about pacemakers in semester 3 and 4. So here is the rhythm strip that shows excuse me, that shows what it looks like. We have the rate is less than 60 when we are counting it out on our rapid estimation. 300, 150, 100, 75, 60, and 50. We're running around 50 here. So is it regular? It's marching out regularly, yes. Is our P's before every single one? Yes. Is our PR normal? Yes, it is. Is our QRS normal? Yes, it is. So all these things, everything's normal except the rate, and that's what makes it sinus bradycardia. Sinus tachycardia is the description of this one is it is a rapid heart rate of greater than 100 beats per minute. It is coming from the SA node. But the rest of the pathway is totally normal. So the big salient feature here is that the heart rate is greater than 100. Usually we're looking at about 100 to 160. Things that can cause sinus tachycardia is it can be just a normal cardiac response to demands for increased oxygen. And this can happen during pain, during fever, during stress, during dehydration, and exercise. I mean, it's totally normal when we start exercising for our heart rate to increase because it needs more oxygen. But stimulants can also be a cause for this. Caffeine or nicotine can stimulate our heart rate, and so we want to be looking out for that. Also, sometimes it can be a sign of early sign of heart failure or a problem after a myocardial infarction. So we want to be thinking of what could be the worst case scenarios here. Collaborative care is if the patient is symptomatic, they're not tolerating that faster heart rate, we need to first look at treating the underlying cause. If it was dehydration, we'd want to solve that with fluids. If it was anxiety, we might be giving them an anti-anxiety medicine. And we might also consider different types of medications that can slow down the heart, beta blockers being one of the predominant ones that we like to give to slow the heart rate. So here is the rhythm strip. You can see that when we do the rapid estimation on this, we've got a heart rate of about 120, 130. When we look at the QRSs and the Ps, they are marching out regularly, so we've got a nice regular rhythm. When we do the P waves, they're all the same. They look the same. They're in front of every QRS. We look at the QRSs, they're all the same, all marching across. We look at the PR, it's normal and it's less than 0.20, that's good. Then we look at the QRS, it's less than 0.12, and that's good. And so we look at this and say, the only thing that's different about this is the heart rate is greater than 100. So that makes it sinus tachycardia. Let's look at the atrioventricular blocks. There is first degree, second degree, and third degree. And this semester, we're only going to really look at the first degree and the third degree. So you don't need to focus too much on it. I'm going to generally describe each one so that you have some understanding of how it all flows. But as far as the test is concerned, we only are looking at first and third degree. Second degree, you will look at in subsequent semesters. So, first degree heart block, it is a delay of the impulse from the atria to the ventricles, and what ends up happening is the PR gets extended to greater than 0.20 seconds. In second degree heart block, some impulses reach and others are blocked, and so what ends up happening is the PR interval will vary. And so there is a type 1 and there's a type 2, and they look different and they demonstrate themselves differently. Third degree, on the other hand, is where none of the impulses reach the ventricles, and this is a very serious problem. And so let's look at these heart blocks more specifically. Here is the first degree heart block. This is where you can see, of course, on this particular rhythm strip, it's also very, very, very slow. But I want you to only focus in on that here the PR is greater than the 5 small squares. In fact, in this case, I believe it's like 8 small squares, like a 0.32. So that's quite extended. probably the reason why this PR is so long is that heart rate is so slow. So that's a whole nother issue, and I don't want you to focus in on that. But I would like you to just focus in on this thing, that everything is moving along the way it should. The problem is that PR is too long. And we see this very commonly with our patients. They'll have a 0.24, 0.28. They won't have any other symptoms than that. On third degree heart block, on the other hand, we have the P waves being sent. You know, the pacemaker just continually is sending out the P wave, that conduction, but it's not getting through. And so the ventricle then has to start its own pacer, and so you're going to see them functioning as if they're totally different. And you can see this if you were to count out that P all the way across. It goes the equal amount all the way across, and the QRS goes equally amount across. But there's not a P wave in front of every single QRS in the same way. And so this one is one that I'll show you in class, because it is sometimes it's not so easy to see when you're looking on the strip. But the P's are not being conducted, and the ventricle rate is slow. Those are the salient features of the third degree heart block, and this is an emergency situation. We really need to intervene. So what are we going to do? So let's look at the collaborative care for heart blocks. First off, always think about, observe the patient, and look at that, see how the patient is responding to any of these heart blocks. Check the PR interval, and realize in the back of your mind that this can develop, especially a first degree, could develop into a more serious heart block. So first thing we're going to do is we're going to treat the cause. We're going to look and see, is there a drug toxicity from maybe digoxin, or from a beta blocker, from a calcium channel blocker, or from an antiarrhythmia. So there's a lot of different agents that could slow down our heart and make it not function and move across the pathway like it should. Another thing that we want to look at is make sure their potassium is normal. So we're looking at a patient, they have a first degree heart block. What are we going to do? Well, usually nothing. Usually there's nothing to do. Usually they have a first degree heart block and they're having no problems. Their heart rate is normal. It's just the PR is a little long, and usually we don't have to do anything. Now, in second and third degree, we do pretty much the same exact thing for them. We are going to start oxygen on them. We're going to give them some atropine to try and increase their heart rate, so sometimes that will solve the problem. And then we're going to consider transcutaneous pacing, or our temporary pacemaker, and a permanent pacemaker if necessary. And of course, you know, if the cause behind the second and third degree is a medication, once the medication is worn off, we're going to be okay. But if it's something else, perhaps an infarct or an injury to the tissue of that part of the heart, we may have to put in a permanent one. Okay, so now let's look at supraventricular, well, we aren't going to look at supraventricular dysrhythmias. Those are arrhythmias that come from above the ventricles, from the predominantly from the atriums. That is going to be covered in third semester when you go over atrial fibrillation and atrial flutter. But today we're going to go through the ventricular dysrhythmias. These are arrhythmias that occur originate in the ventricles, and one of the salient features of them is that the QRS is greater than 0.12 seconds. They are very dangerous because they can trigger ventricular tachycardia and ventricular fibrillation, which we'll go over shortly. Also, the other thing is that we're not including the atrium here, so we've lost our atrial kick, and so that does decrease the efficiency of our heart. Let's look at one of the first ones of the ventricular dysrhythmias, and that's the PVCs. PVCs, the description of this, are premature ventricular contractions. This is an abnormal beat or ectopic beat that originates from some irritable cluster of cells in either the right or the left ventricle. It occurs before the expected beat, so it's premature, and because it's coming from an abnormal pathway, the QRS is going to be wide and bizarre. And you can see there on this slide that the second one is a PVC. It's coming early, it's wide and bizarre, and also afterwards it has a compensatory pause. So it takes a little while before the regular heartbeat starts up again. Some of the different types and terms that we use with PVCs is we talk about unifocal PVCs. This is when they are coming from one site, one irritable focus, and so the waveform all looks the same. Multifocal PVCs, on the other hand, there's several ventricular foci. There's greater irritability in the ventricles, and so because they're coming from different locations in the ventricle, you're going to see a different waveform for each of them. And this is much more dangerous because we realize that the heart is much more irritated. Couplets are pairs or two PVCs together, and that's always not a good thing. Ventricular bigeminy is where every other beat is a PVC. Ventricular trigeminy is every third beat is a PVC. Ventricular quadrigeminy is every fourth beat. And so obviously the bigeminy is much more dangerous than the quadrigeminy, but actually any PVC I don't really want to see. Now we do have some people that have PVCs normally, but smokers are the most common people that we see with frequent PVCs that are not life-threatening, but we have to make sure that that's true. We just don't want to assume, oh, you have PVCs and you're a smoker. Oh, well, I'm not going to worry about them. That's not true. We want to make sure that there's not a problem. And then the R on T phenomena you will hear. This is where there is an early ventricular beat at this time during the R on T in the waveform would put the heart into ventricular tachycardia. So that's a very dangerous time. So you think about how your wave goes PR, QRS, T. There between that R and T is when, if we had a PVC during that time, during that repolarization, that could be very dangerous and put our patient into VTAC. And so our doctor would want to know about that, because the doctor would probably want to intervene with some kind of therapy, some kind of medication to try and prevent that from occurring. So here we are looking at the premature ventricular contraction. You can see on this particular strip, it's on the fifth beat that we have a PVC. Some of the salient features of this: it is bizarre, it's very wide, it's premature. The QRS is going to be greater than 0.2, and afterwards we're going to have a compensation. Now, supposedly the P wave could be here, but many times you don't see it. So there's an argument on whether it's hidden underneath there, but in most cases you can't see it. Okay, here's some rhythm strips. The top one is we're seeing some unifocal PVCs. They're all looking the same. But then when we look at the second strip, we're seeing a multifocal PVC. One is upright, and then the second one is downward. And so that's actually a pair. So it's multifocal and a pair. That's pretty dangerous. And then the last strip there, I have it saying bigeminy and trigeminy, but really it is trigeminy, but you're just seeing it in two different leads. The top rhythm is lead 2, and you can see that every third beat is a PVC. If you look at the next one, we see it in lead 5, so it's the same thing. It just is looking a little different because we're looking at it from a different angle. So what causes PVCs? I have this little thing here for you to help you remember. Hank and Harry have depressed, enlarged hearts. So the primary thing is H is for hypoxia, A is for acidosis, H is for hypokalemia, H is for hypocalcemia, D is for drugs, especially digoxin we look at. E is for anything like epinephrine that would, increase the epinephrine in our lives, such as stress, emotions, fever. And then H is hypomagnesium. So this, you can see that we're really looking at a lot of our electrolytes, oxygen levels, acidosis, drugs, and anything that could stress our hearts. Also, other causes could be caffeine and tobacco, and alcohol can also stimulate. So, what is our collaborative care? The collaborative care is only required when the PVCs are frequent or when the patient has intolerable symptoms. So if they're asymptomatic, we're going to make sure that they don't have any problems with hypoxia or hypokalemia. We're going to look at those electrolytes, we're going to look at their oxygen levels and make sure they're okay. If they're symptomatic, we are going to treat aggressively because we're worried about, especially this patient especially if they are in the middle of an acute myocardial infarction, we want to make sure that we do not allow it to further and have more ischemia and more infarction. And usually PVCs, I always try and think about that PVCs could be an indication of ischemia to that muscle, that heart muscle. Surely there's all these other things that can cause it, but if you have heart damage and that heart is not getting enough oxygen in certain parts of the tissue, that's where the irritability can come from. And so we want to treat them aggressively, so we're going to come with oxygen. We're going to give them nitroglycerin to try and dilate those coronary blood vessels so we get more blood to the myocardium. We're going to go with morphine because that helps with also oxygenation. It increases that coronary arteries dilation and pain as well, and then also antiarrhythmic agents. Typically the ones that we go with anymore are amiodarone, and we also go with lidocaine. Okay, the next arrhythmia that we're going to look at that's a ventricular arrhythmia is ventricular tachycardia. The description of this is 3 or more consecutive PVCs in a row, and it ends up being a rate that's greater than 100. And actually, if you're looking at the salient features, it's usually about 100 to 250. The QRSs are very bizarre and wide in appearance, and they are going to be greater than 0.2 seconds, 0.12 seconds. So, you can see this here that it looks almost like a sawtooth effect, aren't we? And if we were to count it out on this particular one, we're looking at really a rate of, let's see, 300, 150, between 150 and 300 on this particular rhythm. So, what are we going to do? Well, first off, we're going to make sure we're going to run in and see this patient, and sometimes it's just somebody has been scratching their leads. We're always very happy when we've had the scare, but ended up it's just the leads. But basically, when this happens, this is an emergency situation. We are going to immediately, if this patient is unresponsive, which many times they are, there are some people that can tolerate ventricular tachycardia for a period of time, but most can't. And so what we're going to do is we're going to start CPR. We're going to call for help, and we're going to start with oxygen and IV access, and we're going to initiate the ACLS protocol, which is Advanced Cardiac Life Support. And this is a protocol just like what you have with basic life support. This is Advanced Cardiac Life Support on what we're going to do when we see certain arrhythmias and certain things in our patient. There's algorithms for us to follow. And so what I would expect you to do as a student nurse, or even as the nurse, you would run in the room, you would see that the patient is unconscious, you would start CPR and initiate and call for help. And as the first nurse would come in, they'd put oxygen on him. The second nurse would come in and start an IV. All the people come in, we would start the ACLS. And when we do ACLS for these patients, we can anticipate that we're going to need to defibrillate them. We cardiovert them if it's a controlled code, but more often than not, usually we need to defibrillate. Now, my father used to go into ventricular tachycardia on a pretty regular basis. He had a really slow ventricular tachycardia, and he could maintain it for a long period of time. So on a patient like him, you would want to do a cardioversion because he's awake and watching you even though he's not functioning real well. And in fact, we had a situation where he was at home and the paramedics were called, and the paramedics wanted to defibrillate him, and he was not having anything to do with it, and they were at the point where they were going to have the police come in and arrest him so they could defibrillate him. It was quite an interesting situation. I showed up just about that time, convinced them to give him a little Versed. They gave him a little Versed and cardioverted him, and we were fine. But anyways, it was quite an experience. But I digress. Other things we're going to plan that we know we're going to defibrillate this patient. Some of the medications that we know will be given to this patient, certainly the antiarrhythmics. We're going to go with the amiodarone, and we're going to go with lidocaine. Other drugs that they typically give during any kind of a code where the patient has gone down is epinephrine, and they would consider vasopressin as well to help them. Ventricular fibrillation is another arrhythmia, a more serious one. The description of this is it's no organized ventricular depolarization, so you basically can imagine that this is like the heart is like shaking a bowl full of jello. It's not giving you any cardiac output. The patient doesn't have a pulse, they don't have a cardiac output, they don't have a blood pressure. And so there's two different types of ventricular fibrillation that we can see on the ECG. There is coarse VF, where the waves are more easily seen, and they are usually more easily converted. So when we defibrillate them, we're more likely to be able to convert them into a normal rhythm. Whereas fine VF, or fine ventricular fibrillation, is looks a little bit more like asystole, and it is not as likely to convert. So when we defibrillate this patient with fine VF, the odds are not as well that we're going to be able to convert them to a regular rhythm. So here we are. You can see these compared next to each other. We have the coarse VF at the top and the fine VF at the bottom. It is chaotic. The salient features here are chaotic wavy recordings and no discernible rhythm. So what are we going to do? Let's look at the next slide. Collaborative care is this patient. We are going to do CPR. We are going to search and make sure what could be the possible cause. Well, really the way this all happens is you see VF on your screen and you go running into the room. And when you go running into the room, you pray to God that they're shaking their leads again. But, you know, the patient's unresponsive, and we find that that's not true. So then we have to we're going to start CPR, call for help. We're going to initiate the ACLS protocol. And while we're doing all this, when the doctors come in and everybody's doing their stuff, they're going to be searching for a cause. They want to figure out what is going wrong with this patient. Is this patient acidotic? Why are they acidotic? Do they have electrolyte imbalances? Why? Let's correct the cause. They're going to be looking for a cause and correct that cause. And if not, then we got to always be thinking in the back of our minds, what is the reason why this is happening? And of course, as floor nurses, we really need to be seeing these signs and symptoms of problems with our patients long before they end up coding on us. And finally, we're going to look at asystole. Asystole is and going back, I'm sorry, on your VF, we are going to defibrillate that. We want to get rid of that chaotic rhythm. We're going to shock it and hope that a good rhythm comes back. Okay, now with asystole, this is the absence of electrical activity. There is no ventricular contraction, and it's basically what we call a straight line, and you can see that is the salient feature here. Collaborative care for this is that we will assess your patient, not the monitor. So you're going to run in and see that patient. You're going to pray to God that they just disconnected one of their leads. Sometimes the voltage on the lead is just not strong enough. You need to switch them to another lead. But you'll see that your patient's alert and oriented and functioning. If they're not, you are going to have to start with CPR. And so that means that you're going to assess. You're really not going to have enough time to, you're not, I don't know why I put ABCs here, but that's part of your CPR, no doubt. But you're going to initiate CPR and you're going to call for help. And when they start the CPR, the collaborative care here is they're going to initiate that ACLS protocol. They're going to secure their airway and get them an IV access. And of course, in this case, we don't usually defibrillate this because we feel that they don't have any electrical activity going on there. But sometimes in total desperation, we will defibrillate. But as far as a test question would be concerned, you wouldn't defibrillate this. You would just do CPR and initiate with the ACLS protocol. Now, I think we're ended here. I think the next slide is the end. And so I just want to tell you that what we're going to do now is you're going to go over, you've gone over all these, and then we're going to have you come into class for about an hour, and we're going to practice different ECG rhythms. I have a whole bunch of them that you can practice and try and figure out. I'll go over any questions that you have based on the lecture, clarify any things that might not seem so clear, especially like third degree heart rate, heart block, I'm sorry. And we'll have a game, and somebody will win a prize, and maybe a couple of people will win a prize. So I'm looking forward to seeing you. That'll be on March 13th. We'll talk about this in class, whether it'll be 12:30 or 1:30 that we'll meet, and I'll also send you an email to verify that. Thank you, and have a good evening. Oh, and then here you'll see this is the website for you if you want to utilize it. Some people have found it useful.